Osterbauer is a member of our board, has been for a long time. And we're so grateful because he contributes a lot to what we do at the Alaska MS Center. Being a part of our board is pretty exciting, in case I haven't mentioned that in talk to us. Isn't it?
It is.
It's really cool. And anyway, on top of being a neurologist, he's also a great guy. So please give him a warm welcome and thank you.
Thank you.
And again for lunch.
Thank you. Actually, Vicki, this is a weird question to ask you, but can you turn me on?
I already did that.
Thank you.
Let's ask the
All right, so I knew that I was going to, or initially I was going to be speaking right after lunch, and I knew it was a heavy lunch, so I tried to make this light and fairly basic, fairly well, not too scientific or whatever, all right? But relapse is important. A lot of people today have touched on it. So let's talk about that for a little bit. First of all, I have nothing to disclose anymore. I used to, but not anymore. These are the objectives. Boy, that comes out kind of small. So first we're going to talk about what a relapse is, some risk factors, some of the common symptoms, differential diagnosis, and then what we do to treat them. This is the kind of standard standard definition of a relapse, and it's actually a long, drawn-out sentence. I put it into bullet points just to make it a little bit easier to digest. So it's a patient-reported or objectively observed event. So the patient-reported piece of it comes a lot of times. I've got patients in Fairbanks or Nome or whatever. And they'll just call me by phone and they'll say, I'm losing an arm or I'm losing a leg or whatever. And I'm not able to objectively see them, but most folks with MS know their bodies pretty well, so they know when a relapse is coming. So patient-reported event, sometimes just over the phone they'll say, I'm starting to relapse, I need steroids. So that's that piece of it. Or an objectively observed something where they come in the office and, got double vision or, dragging a foot. It's something that's typical of an acute inflammatory demyelinating event in the CNS, so just something brain, spinal cord. Current or historical. The historical piece, a lot of times I'll see someone in follow-up and I'll say, how you been doing? And they'll tell me about a relapse that they had 3 months ago, and they just thought, like Wendy was talking about, you want to kind of be in denial a little bit sometimes. So we don't always catch the relapses when they happen, but it still fits the definition of a relapse. One of the key things is it needs to have a duration of at least 24 hours. We'll talk about that in a little bit here. And absence of fever or infection. So anything that heats up the body, again, like Wendy was talking about, exercise, hot showers sometimes, anything that heats up the body, but fevers and infection can do it. I tried to find a simple slide to go over the basic pathophysiology of a relapse. All the slides that I found looked like someone had shot it with a paintball gun Uzi, and I didn't want to do that to you after lunch. So very basically, there's a normal neuron with the myelin bubbles around it. Immune response gets all excited in the system, attacks the myelin, and that causes the relapse. So these are some things that can precede a relapse. You don't have to have any of these things, but if someone is going through one of these, you might want to be a little bit more aware. So the postpartum period, for whatever reason, we're still not exactly clear. There's different theories, but nothing's really been 100% proven yet. But for some reason, about 3 months after a lady gives birth, a lot of times that's, around the time where they might have a symptomatic relapse. Any kind of illness, anything that knocks the system back can set someone up for a relapse. And the thought behind this is, so MS basically is a disease where the immune system is working too good, right? It's all ramped up and it's attacking your own cells. So, oh hey. So when you get sick, the body, let me back up, the disease-modifying therapies try to calm down the immune system. So when you get sick, the body tries to ramp up the immune system. So you get an extended immune response, and that extra immunity can cause a relapse. Physical or emotional stress, and this Mo touched on a little bit earlier, and like she said, there's not a lot of good, there's some anecdotal stuff. I've seen it myself, but there's some thought that stopping disease-modifying therapy could put someone potentially at risk for a relapse. And like Mo was saying, it may not be necessarily a relapse, it may just be going back to how you were going to be in the first place. But I have seen myself with Tysabri, and again, it's about 3 months after stopping, I have seen that in patients where they have a relapse. And then this is sort of, I found different lists of what the most common relapse symptoms are. This one goes along with what I've seen in my experience, and they all sort of fall in this general parameter, so you might find different ones, but this is fairly accurate. The most common that I see, the most common reported are sensory symptoms, numb arm, numb leg, numb side of the body. That can also include pain, like the MS hug, you know, where you get the band of pain around your middle. Optic symptoms like the optic neuritis, that's the second most common. Brainstem symptoms, and this is just any cranial nerve stuff. It can be the double vision, it can be vertigo, Bell's palsy type thing, anything cranial nerve. Motor symptoms like the weakness, cerebellar, and that goes along with the balance, the dizziness. And bowel and bladder symptoms, it's part of this list that I stole from that reference that you can't read. So I left it on there. I've never seen someone that came to me with bowel or bladder relapse, So I'm not exactly sure what how that plays into things, but I left it there. So this is, Dr. May did an awesome job about the optic neuritis. I've got a few slides on it here, but this is an example of optic neuritis on an MRI. You can see the optic nerves. This is the inflamed one. It's lightened up with contrast. And that's how it should look dark. And then this is the frontal view. That's how it should be. And over here it's bright. And again, I tried to be as simple as I could. For a neurologist in med school, I hated neuroanatomy. I think it was probably the professor. I don't know. He wasn't mean or anything. He just was very boring. So some of these slides kind of brought back a PTSD reaction. But I thought that it would be nice to at least sort of understand how the pupillary reflex works, because with optic neuritis, there's something that providers can look for called an afferent pupillary defect. And it's where the pupils don't constrict like they should. So what happens is, or what should happen, is you've got the eyeball here in this beam of light. So the beam of light comes in, goes down the optic nerve, and then right here at the chiasm it splits, and it goes both ways. So it hits both sides, and it comes through this little circuit here, and comes around, and it constricts both pupils. So shining in one eye constricts both pupils, right? Well, with an optic neuritis, if you shine it in the eye and the optic nerve isn't working well, it's not going to constrict as well. It might constrict a little bit, or it might not constrict at all if it's really bad. So that's how it works. Does that make sense? Mm-hmm. All right.
On the side you shine it in or both sides?
It'll constrict on both sides.
It'll constrict on both sides.
Yep.
I mean, but what I'm saying is, if you have MS, it will.
Oh, yeah, it won't constrict on either side as well. Yeah.
Visibly with the eye?
Yep, I've got a video for you.
Oh, great.
So there's a test that they call the swinging flashlight test. And you need to do it in at least a semi-darkened room so you can see it better. But you take the flashlight and you go from eye to eye and you watch to see if the pupils constrict. And they should, in a normal eye, or normal brain, normal optic nerve, they should constrict on both sides fairly equally. You have to hold it for at least 3-ish seconds on each side to give it a chance to, because it'll kind of move a little bit at first. The other thing is, does anyone know the most common cause of non-reactive pupils? It's weak flashlight batteries. So you want to make sure you get a bright light. All right. So there's a guy talking in the background. I think it might be Dr. May. I'm not sure. But
in this patient, you will see that the right pupil consistently dilates.
see how that one constricts, and then when you go to the other one, yeah.
Relative afferent pupillary defect. It usually signifies that an optic nerve lesion is
So
present on the
constricts on the good side, and then dilates on the bad side.
and the only objective way to demonstrate
It's not always that obvious. It's sometimes hard to see, especially someone with dark eyes, dark brown eyes. It can be hard to see, but it can be helpful. And this is kind of what optic neuritis might look like from a patient's perspective. I've never had it, so this was done by a patient. But that's the normal bright red car. This is that, like Wendy was talking about the Vaseline over the eye. And then we were talking in the board meeting the other night about the red desaturation and problems with red. And so you can have problems with color perception, and the bright red car is sort of dull. So that's one thing that you can use to test also. You can get a red something, a red pen or whatever, and have them cover one eye and, is it red, orange, whatever. And whenever I do a talk, I try to look on the internet to see what patients are seeing. And this is what came up. These are what are recommended to treat optic neuritis. They saved their number one treatment for last. They felt like Epsom salt baths was the number one treatment for optic neuritis. They said you take a Epsom salt bath and your optic neuritis will go away over time. And like Dr. May told us earlier, your optic neuritis will go away over time anyway, however many apples you eat or however many salt baths you take. But
they feel
if that's what you believe, yeah, you feel good. Differential. So there's something called a pseudo-relapse, and I didn't break that big long sentence down into bullet points like the other one, but basically you get an exacerbation of symptoms associated with heat exposure. And again, it can be a hot shower, it can be exercise. Folks in Alaska have a lot of hot tubs. That can do it. Saunas, anything that increases your body temperature, or infection, like fevers. And normally, this is worsening of some symptom that the person has already had. Like some people have a foot drop. And it gets better, and most of the time it doesn't bother them, but if they take a hot shower or sit in the sauna, they'll start dragging their foot a little bit. So it's something that they already had. It's not necessarily a new symptom. It just gets worse because of the heat, and then after a couple hours of being out of the heat, or sometimes overnight, sometimes they just have to sleep it off, but it'll go away. And that's one of the reasons that the 24-hour criteria is in the definition of a relapse. Something else I was going to say about that, but it'll come back to me. Other neurologic disease. So this is something that can be overlooked sometimes. Mo said earlier that it's kind of the great mimicker, the great pretender, I think she called it, because MS can look like just about anything. I mean, you can have all kinds of weird symptoms with it. But we have to remember as providers that just because someone comes in with a facial droop doesn't necessarily mean it's an MS relapse. It could be a stroke, it could be a TIA. Just because you have MS doesn't mean you can't have a stroke. I've got one lady that has MS, but she's had 2 strokes too, you know. So you can't just blow off symptoms. Sometimes it could be just a complicated migraine. You can get weird neurologic symptoms with a migraine. I've had people lose an arm or a leg because of their migraine. Not lose it, but you know. So you have to make sure that you can't just chalk it up to MS and blow off everything else. You have to make sure that you're a good provider and you're not missing anything. And then other paroxysmal symptoms. Paroxysmal just means it kind of comes on suddenly and drives you crazy. So pain, muscle spasms. Relapse sign, have you all heard of that? It's when you look down and you get like electrical sensation down your back. And it can be anything from a mild tingle to like a explosion. Sometimes it can be really painful. That's Relapse sign. And a lot of times that'll happen after a shower. I've heard a lot of people tell me that they get, you know, after they take a hot shower, if they look down, they get down the back of their spine. And then Uthoff symptoms, that's visual symptoms having to do with heat. And again, a lot of times it's after a hot shower. They'll get out and their vision will be blurry for an hour or so, but that goes away. And then there's normal fluctuation. I mean, anyone with MS knows that their symptoms just naturally can fluctuate from day to day or week to week, month to month or whatever. You know, it's not just a steady course. It's kind of ups and downs, good days and bad days, depending on what's going on. So it might not be a relapse. It might just be normal symptomatic MS fluctuation. And then functional is a funny word. In my first year of residency, I was doing my first neurology rotation, and they were talking about, oh, this patient's symptoms are functional, and I thought functional meant it was working. Functional means they're crazy. So, not crazy, psychosomatic. Wendy talked about Lyme disease earlier.
My Lyme disease turned out to be psychosomatic. You're crazy? Oh, man, she was faking it.
So it could be that. And just because it's psychosomatic doesn't mean they're purposely faking it. Sometimes it's honestly subconscious. I've seen people that honestly, truthfully, you know, had something going on, and I believe in my heart that they weren't faking it. They just, yeah, sometimes they are faking it too. So something else to look for. When do you treat it? That's a good question. And there's a lot of, I mean, I hate to use this expression because it's kind of cliche-ish, but probably any neurologist you ask this would have a different answer. So you have to, or I say you, the way I do it is I sort of I try to get a good feel for my patients. I try to get to know them and their lifestyle. And if they have a relapse, I try to base it on their situation. You know, everyone's different. So I feel like you can't just treat everyone the same way. So this is what I use to figure out what I'm going to treat. Most of the folks that I have that have the optic neuritis or visual symptoms do want treatment. And again, just like Dr. May said, it doesn't necessarily make it better, it just makes it get better quicker usually. In other words, long term, it doesn't mean that they're gonna do better, but they do get better faster. So most of my folks, and the pain, the optic neuritis can be painful, and it'll help with the pain too. So most of the folks that I have that have a optic neuritis flare do want treatment, so I'll treat them if they want me to. Anything that's limiting their activities of daily living, you know, if it's a mom with 6 kids and she's dragging her foot or whatever, or can't stand up because everything's spinning, that's a good reason to treat. And then patient preference is a big one too. Sometimes, you know, they have this thing they call the art of medicine. You know, there's a lot of science that we deal with, but then there's an art to it too. And like I said, everybody's different. And sometimes someone will call me up and they're worried, and to me it doesn't seem like a huge flare. You know, maybe they've got some numbness in an arm or whatever. Whoops. Maybe they've got some numbness in an arm, and to me it doesn't seem like that big of a deal, but to them it is. You know, I had a lady just a couple weeks ago that her only symptom was she had the band-like pain, but it was driving her crazy. It was horrible. It was really impacting her quality of life. And she wanted treatment, so I treated her. What's that? Yes, yep. And speaking of that, here are the options. The options that we have right now. Watchful waiting, oral steroids. I'm going to talk about each of these separately in a second. Oral steroids, IV steroids, Acthar, and plasmapheresis or IVIG. Watchful waiting is always an option, especially if the symptoms are fairly mild, like just some numbness or tingling or whatever. If it's not significantly impacting their daily activities. And again, patient preference. I've had some folks that can't see out of one eye, but they don't want treatment. Okay, you know, dragging my leg and I can't go to work, but I don't want steroids. I'm not going to force you. So oral steroids is an option. There's one study, they followed people over 10 years. They got oral steroids and IV steroids for optic neuritis, and this one found that there was a little bit higher risk for recurrent optic neuritis if you use oral steroids. So a lot of, you can use oral steroids, I'm not saying you can't, but most of the time, if it's an optic neuritis, I prefer IV, and I think most neurologists would do IV. That shouldn't say caution. I thought I changed that word. It should say awareness when on Tysabri, because it's not really a caution. Steroids isn't contraindicated in folks with Tysabri. You just have to be a little bit more aware of them because of the PML risk. So if they're JCV positive, JC virus, then use a little bit more caution, watch them carefully. You can still use them. You don't have to alter the Tysabri dosing schedule or anything like that. You just watch them a little more carefully.
And what could happen?
The concern is to knock the immune system back far enough that the JC virus activates and it causes the PML. Yeah, so that's what we don't want to happen. And so the oral, there are different protocols. This is sort of the standard one, 1,250 milligrams a day for 5 days. That's a lot of prednisone. Yeah. And I've only used oral a couple times, and it's been by patient preference. IV is just easier. Sometimes it's a pain in the butt to get them in, but it's easier overall, and to me it just works a little bit more smoothly. But if someone can't get in or whatever, for whatever reason they want to do the oral, you can do the oral. It's just a lot of prednisone. And so I always recommend giving them some kind of either Zantac or a proton pump inhibitor or something to protect their gut, because I mean the IV can affect the gut also, but the oral, I mean, it's getting directly in there, so it's a little bit rough around the gut. Make sure they take it with food, make sure they take it in the morning so they don't stay up all night, and it tastes nasty, so warn them of that. You don't have to do a steroid taper if you don't want to. Some people do. I usually don't unless they start having withdrawal symptoms. IV steroids is probably the most common. Again, yeah, see, I changed it to awareness on this slide. I just didn't do the other one. Awareness for the folks on Tysabri. Usually it's Solumedrol, 1,000 milligrams a day for 3 to 5 days. Some people go 7. And that's just based on the severity of the flare. You know, if it's fairly minimal, we'll do 3 days. If they're having quite a bit of disability, we'll do 5 or maybe 7 days. And again, you don't need a taper. Acthar is kind of cool, but it's really expensive, so you have to have a good reason to use it. And someone that does not respond to steroids, you know, either they've gotten a round or 2 of steroids and they're still having problems, or in the past they have a history of not responding to steroids, or if they have reactions to steroids, they can't tolerate them. Those are reasons to use Acthar. One caution, it's made out of pigs. So if someone has religious things where they can't have pig products, or if they're allergic to pork, then just make sure you ask them, are you Jewish? Are you allergic to pigs? You know, anything like that. Just something to keep in mind. And the dosing varies. The standard is 80 milligrams a day for 5 days. You can go 80 to 100 milligrams, or 80 to 120. You can go 2 weeks. It just it's one of those art of medicine things. Again, you base it on the patient, what's going on, and what their insurance will approve. This is, I stole this from the Acthar website. This is the proposed mechanism of action. It's not really sure yet how it works, but there are these melanocortin receptors. There's 5 of them that we know of so far. And these are the different areas that they hit. Only one of them has steroid properties. So what Acthar does basically is it stimulates the body's own steroids to come out and do their thing. But it affects these other melanocortin receptor areas too that are not steroid dependent. So it can affect the microglia, which are the cells in the brain that chew up the myelin. Different CNS cells, immune cells, and so it suppresses the microglia. Again, those are the ones that chew up the myelin. The T cells are thought to be one of the first bad guys. Well, not bad guys, they're good guys, but then they get some friends on the wrong side of the tracks and they change their ways and start doing bad things, and they squirt out cytokines and they activate B cells and these other T cells. But anyway, the Acthar, through the melanocortin receptors, suppresses all of those. And then plasmapheresis or IVIG. So plasmapheresis, you probably know, you take blood out, filter out the bad stuff, and put it back in. Not the bad stuff, the good stuff. That's an option. And then IVIG is immunoglobulin cells, which are just like immune cells, basically, that you add to the person's bloodstream. And they're decent treatments. They're just expensive. They can be hard to get set up. Insurance can be a problem sometimes. But there may be a place for them. I've used IVIG in pregnant ladies. I haven't used plasmapheresis myself, but I mean, it is an option. And the protocols vary quite a bit. Usually with IVIG, you do 0.4 grams a day for 5 days. And IVIG is great. I used to use a lot of it when I was in Texas because we had a lot of CIDP, which is a chronic inflammatory neurologic disease. Treat that with it and different things. And it's a good treatment, but it can make you sick. It can really cause some nausea. It can make you feel drunk. Some people it doesn't bother them at all, but it's a good one to use for someone with a flare that's pregnant because it's safe in pregnancy. And let's see, again, if they're not responsive to steroids or can't tolerate steroids, that's an option. And like I said, I wanted to keep it fairly light and not too long because I knew it was going to be after lunch. And so that's what I've got for you. Any questions?
How does IVIG work?
Yeah, so IVIG, the question was, how does IVIG work? It's basically immune cells that go into the person's body that bind up the bad cells. So the thought is that we don't have enough of our own good guys to bind up the bad guys. So there's the bad guys that went off the wrong side of the tracks and made bad friends and everything. And they just need to be placed under arrest. And so, yeah, these are just cells that go in there and arrest the bad cells. Does that make sense? Okay, yeah.
And I hope this isn't a silly question, but when you were talking about the symptoms that were real common
Mm-hmm.
in relapse, number one was sensory, and that really surprised me. And why, do you have a theory for why it would be sensory?
That's a
Why
silly
that's-
question.
Well, it feels silly, because it's
I'm
like,
just
I was
kidding.
so surprised that I was so surprised by the order of things.
Yeah.
'Cause I guess I expected it to be more like muscular.
Yeah, you would think more motor.
That's what I thought
Yeah,
would be
you
normal.
would think more motor.
And
Yeah, and
that's a big surprise.
probably what happens is the ones that are noticed more are more the motor, because the sensory ones, a lot of times people just kind of shake them off or ignore them.
So I wouldn't see
So,
that.
right,
So
you might
that's the
not, yeah.
difference, is that, as a person, as a third party, I'm not going to see.
Right, right.
It's just,
Yeah, you'll see someone come in dragging their leg or whatever,
Absolutely.
But, they may just, my arm's tingling, it'll go away,
Okay.
So, yeah. All right, anything else?
I would think that some of the postpartum flare-ups might be because of the connection between the HP axis and what else is going on with that woman, just having a baby.
Right, I think so too. Yeah.
Because the pituitary is right there.
Yep.
Playing along with everybody else.
Yeah. Yeah, I agree. I think so too. Yeah. Oh, yeah.
Are there any, I hope this isn't too specific a question, are there any real firm guidelines on how low the lymphocyte count would have to be in order to consider a risk of PML for somebody who's on either Tisabri or Tecfidera?
Right. So the question is, are there any guidelines of how low the lymphocyte count has to be before for someone to be at risk for PML? And that's a really good question. We don't know the answer yet. They're trying to figure that out. There's with Tisabri, the general sort of number that I look at is 5 on the white count, but it's not, we still don't know. They're trying to figure that out. But yeah, it's a good question.
Is there cause for awareness or caution for any other DMTs using steroids with a relapse?
Right, cause for any caution with other DMTs for using steroids, not that I'm aware of. Yeah.
So when you have someone on Tisabri, how often are you checking the lymphocyte counts and such?
I usually don't check them on Tisabri just because we don't know what to do with them. So I monitor the JCV index, and I get, if someone's JCV positive, I get more frequent MRIs. Yeah.
Do intercurrent illnesses include things like out of control diabetes mellitus? I mean, would you want to get their sugars under control before you start giving them steroids?
Right. Yeah, and that's another trick too. Yeah, with someone with diabetes, you have to be careful with the steroids, especially with high doses like this, because their sugars can go crazy.
With that recurrence, though, would you want to get that under control before you start treating their recurrence as a relapse as a relapse?
Yeah, so the question is, do you want to get the diabetes under control before you start treating the relapse? And it would depend on how bad the relapse is. If it's a really bad one, I'd do them at the same time. Otherwise, if you have time, if it's not too bad, it would be a good idea to get the diabetes under control first before the steroids. Yeah. And then have their endocrinologist give them the steroids. Pass the buck.
How often do these relapses typically last? Is there kind of a time frame?
No, there's not. It's variable from person to person, and even within the same person. It can be anywhere from days to months. And it's frustrating for the patients especially, but even for me as a doc, it's frustrating because someone has a relapse and their first question is, how long is this going to last? And all I can say is, I don't know. I hope not too long. But yeah, even within the same person, I've seen people that have had a relapse that was a week long, and then the next one is 6 weeks long or whatever. So there's a lot of variability. Yeah.
Is there sort of an average frequency of relapsing, or is that real patient specific too?
Yeah, and is there an average frequency of relapse? And that's patient specific too. I saw different numbers when preparing for this, and kind of the average that I saw was 1 to 3 per year. I don't necessarily see that personally in my own practice. My folks, I think it's just because I'm a really good doc, my folks are pretty well controlled. I don't see a whole lot of relapses.
And was that later on in the disease course, or?
The ones that I saw here?
When a person might start seeing relapse?
Oh yeah, at any point.
Any point?
Yeah, any point. It's another part. The frequency of the relapses and the length of the relapses is totally unpredictable. It's just roll the dice and see what happens. And it's, like I said, it's frustrating because that's the other question I get is, when am I going to relapse again? I don't know. Throw a dart at a calendar and yeah.
length of time that you have that relapse, that particular symptom, that now it's going to become permanent.
Right. So when you have a relapse, is there a length of time that you have the symptom that it's going to become permanent? So in other words, my arm has been numb for a month. Is it going to be permanent now? And I mean, this is going to sound like a flimsy answer, but it's the truth. The longer you have the symptom, the more likely it's going to stay. Like I said, it sounds like a cop-out answer, but that's the answer. All right.
Well, thank you
Thank
very
you.
much.